This video is part 3 of 4 of the cardiovascular system, blood vessels and circulation. When we talk about how blood flow is regulated through the human body, understand that there are intrinsic controls within the blood vessels themselves, which we refer to as autoregulatory mechanisms, and extrinsic controls, which come from the nervous and endocrine mechanisms. When we look at autoregulation, that's what happens at normal resting conditions. And there can be changes in blood flow that are detected by local receptors, and that can cause changes in the smooth muscle that affects the arterioles. And in blood vessels themselves, there are endothelial cells which are able to produce nitric oxide, which will help to vasodilate. Understand, though, that nitric oxide is very quickly broken down, so it's a very short-lived mechanism for vasodilation. So we have different chemicals that will cause vasodilation to occur, and other chemicals like prostaglandins, which are normally released in inflammatory processes, or platelets, white blood cells, endothelins, which can cause vasoconstriction. And again, that can either relax or constrict precapillary sphincters or capillaries in different areas of the body. That can cause either an increase or decrease in blood flow. And again, it's a very, very small way of regulating blood based on tissue needs. And when we talk about the regulation of blood flow, if you think of it in terms of your house has a main water supply, and you might go through your house during different times of day, turning the water on in the sink to wash some dishes and then turning that off, or maybe turning the water on for a shower, turning the washing machine on, which would use water. So it's basically regulating flow in a very similar manner, only we're talking about the body instead of your house. When we look at neural and endocrine mechanisms, we've already discussed the fact that there are cardiac and vasomotor centers that can respond to changes in blood pressure as well as blood chemistry, and so that response will help restore homeostasis by bringing us back to normal. And then with the endocrine control, remember the renin, angiotensin, aldosterone system, where that will help raise blood pressure, and so we can regulate blood volume and blood pressure with that system. The adrenal gland will produce and release the catecholamines epinephrine and norepinephrine, which will increase blood pressure because of vasoconstriction. And we know that the brain produces antidiuretic hormone in the hypothalamus, where it's stored and secreted by the posterior pituitary. And then our heart in the right atrium actually produces the hormone atrial natriuretic hormone, and again, that will be produced and secreted when there's stretch in that right atrium, because then the heart thinks, well, there's a lot of volume of blood, so we've got to get rid of some fluid volume by excreting more in the kidneys, and that's how that works. So again, we're constantly regulating blood pressure and blood flow because we need to be able to make sure that blood flow is adequate, blood pressure is adequate, and that we have adequate distribution of blood throughout the body and adequate perfusion where the tissues are getting the blood gases, oxygen that they need, nutrients that they need, and also getting rid of carbon dioxide and waste products. As we look more closely at neuroregulation, understand that there are higher brain centers that can modify arterial blood pressure by way of relaying information to and from the medulla oblongata. But remember that it is within the medulla oblongata that we find the regulatory centers for heart rate and blood pressure and respiration rate. So this is where we see clusters of soma, which are neuron cell bodies that form nuclei that even though they're indistinct anatomically, they form centers such as the cardioacceleratory center, which increases cardiac output, or the cardioinhibitory center, which would decrease cardiac output. And there are also vasomotor centers within that area of the medulla oblongata. And the vasomotor center acts predominantly through the sympathetic nervous system to release norepinephrine that will act on the tunica media, that middle layer of blood vessels. And so within the brain and the skeletal muscles, we also find cholinergic neurons. And if the word cholinergic sounds like acetylcholine, well, that's what those neurons release. They release acetylcholine, and that prompts the inner cells of the blood vessels, the endothelium, to release nitric oxide, which is a powerful vasodilator. However, nitric oxide is a molecule that can be broken down pretty rapidly. So when nitric oxide is released, although it will cause vasodilation, it gets broken down pretty rapidly. Now, some of the neurons in the brain and skeletal muscles will release norepinephrine, and some will also directly release nitric oxide. But as far as blood vessels go, well, you'll remember that with skeletal muscle, we had skeletal muscle tone, because there are parts of skeletal muscles that are continuously undergoing this partially sustained contraction, and they'll switch throughout a motor unit, and that gives us muscle tone. And just like skeletal muscles have skeletal muscle tone, there's a similar thing that occurs in blood vessels. Arterioles are normally always partially constricted, and when we have maximum stimulus of the sympathetic nervous system, the radius for that blood vessel can be reduced to 1/2 of its resting state. So full dilation of arterioles means that sympathetic stimulation must be suppressed. And when it is, an arteriole can actually expand as much as 150%. And that kind of increase can really affect resistance, pressure, and flow. Let's take a little bit closer look at some more on regulating blood flow. We know that baroreceptors are part of the neuroregulation because we have baroreceptors in the ascending aorta that makes up what we call the aortic sinus, that area where we have these special little baroreceptors, and that aortic sinus is actually just superior to the aortic valve. But then we also have our carotid sinuses located at the base of the internal carotid arteries. And so these baroreceptors are going to send signals to the medulla oblongata when we have increase in stretch, and that would be caused by an increase of fluid pressure. And we also have located in the vena cava, as well as in the walls of the right atrium, special baroreceptors that detect low pressure. So if there's not enough pressure, those low pressure receptors will be stimulated, and they will send signals to the vasomotor centers and the cardiac centers in the medulla oblongata. As you recall, we also have chemoreceptors, which form the aortic bodies and the carotid bodies, and those chemoreceptors are going to monitor levels of things like oxygen, carbon dioxide, free hydrogen ions, which is our pH. And so if there's an increase in carbon dioxide, we're going to have an increase in cardiac output. And the respiratory system has to comply with the changing demands in our body chemistry. So if a person is exercising more, well, he's building up more carbon dioxide in his bloodstream as he uses up oxygen more quickly. So we have to have the respiratory centers in the medulla oblongata increase the rate and depth of breathing. And then we also have the chemoreceptors, again, the aortic and carotid bodies, which are sending signals to the medulla oblongata that are going to make changes in our blood vessels. So we've got changes in vasomotor tone as well as changes with our cardiac output. So all of these systems are working together to make sure that we're getting adequate perfusion throughout the body. And obviously the limbic system, which helps regulate emotions, sympathetic and parasympathetic nervous systems are going to play a role in this. So that is how chemoreceptors are involved in neural regulation. Again, if it's a receptor, it's going to send signals. That's the nervous system. Remember? Pressure sends signals, nervous system, chemicals, temperature. Okay, those are all different kinds of receptors which involve the nervous system. With endocrine regulation, remember we've got the catecholamines, epinephrine and norepinephrine, which are going to be released by the adrenal medulla during sympathetic nervous system activation, fight, flight, or freeze. We also have antidiuretic hormone, which is produced in the hypothalamus but stored and secreted by the posterior pituitary, which is going to help resorb water back into the body, preventing the excessive loss of fluid. And then we have the renin-angiotensin-aldosterone system, which is going to help vasoconstriction, and it will cause the release of antidiuretic hormone and aldosterone. When blood pressure falls, the renin-angiotensin-aldosterone system kicks in to help build blood pressure back up. We also have erythropoietin, because if there's not enough blood flowing through the body, if blood pressure falls, then the tissues and the cells are not getting enough oxygen, and that will stimulate the kidneys to release erythropoietin, which stimulates red blood cell production in bone marrow. And then finally, we've got atrial natriuretic peptide hormone. That's where the ANP comes from, atrial natriuretic peptide hormone. And that is going to be stimulated to be released when the atria are receiving a lot of blood coming back to them, because if there's too much stretch in the atrial walls, then that will cause the release of this hormone, because the idea is that we want to not have too much fluid in the system. And so that will actually promote the loss of sodium from the body, and water will follow, so we're going to pee out more. It suppresses the renin-angiotensin-aldosterone system. It suppresses the release of aldosterone. It suppresses the release of antidiuretic hormone, because if we've got too much blood coming back to the atria, we need to get rid of some of that excessive fluid. So this takes us to the autoregulation of perfusion. So there are chemical responses that occur from chemical signals which work at the level of the precapillary sphincters. And so remember, we've got those little sphincter muscles in the arterioles right before the capillaries, and those smooth muscle sphincters will dilate or open up in response to a decrease in oxygen, an increase in carbon dioxide, in response to an increase in lactic acid or metabolic byproducts, like an increase in acidic products. So if we have falling pH, that means it's getting more acidic. They'll also dilate in response to histamine. Histamine causes increased capillary permeability and also increased blood flow in response to inflammation. And they'll also vasodilate with increased body temperature. So the conditions of these different chemicals will cause the endothelial cells to release nitric oxide, and the contraction of those precapillary sphincters will be triggered by the opposite conditions of these chemicals. Now, there's also a myogenic response that can occur at the level of the smooth muscle in the arterial walls. If there's a lot of stretch from high flow, that will actually cause a reflexive vasoconstriction to reduce flow. So we've got stretch, it's like, wait a minute, slow down, let's constrict it a little bit. And then if there's too little flow, then it's going to open up, it'll vasodilate to increase the blood flow to maintain more constant perfusion. And all of this is what we call autoregulation. It's very intrinsic, it's very local, as opposed to the extrinsic neural and endocrine factors. So what happens when a person starts exercising? We've touched on this before, but remember that the heart, we're going to see increased cardiac output, and that can also increase the size, the physical size, mass, and the efficiency of the heart. So people who are really good athletes who work out a lot tend to have a lower heart rate because their heart is a more efficient pumping mechanism. We also see increased perfusion of tissues. We see that venous return increases through the blood vessels, so the preload is going to rise and the heart rate is going to lower. And we also see a decrease in the formation of plaque and lowered cholesterol with exercise. So if there is a condition where blood pressure is chronically elevated, so if 3 separate consecutive readings are done over a matter of weeks or months, that would be considered hypertension. And hypertension would be an elevated reading normally of 140 over 90. However, some sources are going to anything that's elevated over 120 over 80. And the thing to keep in mind is that everybody's body is different, because for me, my normal blood pressure is about 90 over 60. And then as people get older, their blood pressure tends to increase with age. It's a normal part of the aging process. So as long as it's not too high, and as long as it doesn't get to the point of hypertension, it's usually not an issue. So hypertension is often known as the silent killer because it can lead to things like heart attacks, strokes, aneurysms. It can lead to peripheral artery disease. It can lead to kidney disease, simply because when there's too much pressure in those tiny little capillaries, that can cause them to burst, and that can lead to a lack of tissue perfusion, and it can cause tissue death. We know that blood is toxic to neurons. So if there is an aneurysm that bursts in the brain, that can cause tissue death in that area. And by the way, an aneurysm is when a blood vessel balloons out. That's what an aneurysm is. So if you remember those long balloons when you're a little kid and you take a nice big breath and blow into it, and there's this big bubble in the middle of it or in the beginning of it when you start out, that's what an aneurysm would look like. It's a ballooning which thins out the blood vessel wall because it's stretched in that one area, and that can cause a rupture, which is why they're so dangerous. So when we look at hypertension, primary hypertension occurs in about 90% of all cases of primary hypertension, and there's no one particular underlying factor. And there are lots of different things that can contribute to primary hypertension, like heredity, too much salt, too much fat, obesity can cause primary hypertension. Usually when people start to become older, some people over the age of 40, if they haven't kept themselves fit over time, then they might develop primary hypertension. Diabetes mellitus can definitely lead to primary hypertension because in a condition where there's too much sugar in the bloodstream, that sugar tends to stick on red blood cells and on the walls of the blood vessels, and it makes it harder for blood to flow, and that causes increased resistance. So that's going to build up pressure. For people who are type A, who are under a lot of stress, that can lead to primary hypertension as well as smoking. Secondary hypertension is the remaining 10% of cases of hypertension, and that is due to more identifiable causes like arterial sclerosis, kidney disease, obstructed arteries in the kidneys, hyperthyroidism, Cushing syndrome, in which a person is producing too much cortisol. Those can all lead to secondary hypertension. Now, on the opposite end of the spectrum, hypotension is when blood pressure falls below 90/60, usually. And again, these readings are guidelines, because remember, everybody's body is different. Hypotension can be associated with the elderly people and their ability to maintain enough pressure, and this is a concern if it causes inadequate blood flow, and this can lead to dizziness or fainting. The elderly in particular are prone to something known as orthostatic hypotension, which is a temporary drop in blood pressure when a person goes from a seated position to standing, and now all of a sudden the heart has to pump blood against that much more gravity to get to the brain, and that's why they get that dizziness or faint feeling. Or if they go from a position where they're lying down and they get up too quickly, the best way to deal with elderly people is to take them from a position where they're laying down and get them sitting for several minutes and making sure that their body has adjusted to that new position before you get them to stand up and walk. And again, the sympathetic nervous system is really important in helping to maintain that blood pressure. And as people get older, and this doesn't happen with everybody, but some people who, as they age, their nerves just don't work as well as they used to, and that can be due to a lot of factors. People, as they age, tend to be more sedentary, and it's so important to stay active throughout all phases of life. So some clinical considerations in looking at the ability of blood vessels to maintain homeostasis. If there's a decrease in blood pressure and volume, remember the endocrine and neural mechanisms are going to kick in. So on the endocrine side, we've got, if there's a decrease in blood pressure, we're going to keep fluid volume in the body. So we've got antidiuretic hormone, don't pee, don't lose too much fluid. The renin, angiotensin, aldosterone system. So you can see angiotensin 2 and aldosterone in that next box. Erythropoietin will be released, so we have enough red blood cells to carry oxygen. And so those factors will increase blood volume, because if we increase erythrocytes, that also increases the volume of blood. So that can help restore homeostasis, and our neural mechanisms will kick in at the same time. So we'll see that our baroreceptors and chemoreceptors are going to be stimulated, and our cardiovascular centers are going to be stimulated, and we're going to have a general activation of the sympathetic nervous system, which releases epinephrine and norepinephrine, those catecholamines, and so that's going to increase cardiac output while increasing blood pressure, and we're going to actually see a decrease in venous reserve. Remember, that's where most of our blood in our body is held in reserve, in a reservoir. So that venous blood flow is going to increase to get blood to flow back to the heart, so we can get that circulation going again, restoring blood pressure and volume. if the body can't maintain homeostasis because conditions are not allowing it to, in terms of blood vessels, this can cause a life-threatening condition known as circulatory shock. So circulatory shock is where the cardiovascular system is not able to maintain enough blood flow to supply oxygen and nutrients and get rid of carbon dioxide and waste to the body's tissue, so we don't have adequate perfusion. And this can present in different ways. One way circulatory shock can occur is with hypovolemia, which is typically caused by hemorrhage where there's a large amount of fluid loss, and that presents as tachycardia, which is a very rapid heartbeat because the heart's going to try and pick up the pace to get blood flowing through the body. There's not enough pressure. Let's kick out more rapid heartbeats to see if we can't increase the flow of blood. It also presents as a weak, rapid, thready pulse and shallow, rapid breathing because the body is going to also try and get more oxygen to get through the system. That's one type of circulatory shock. Cardiogenic shock is the inability of the heart to maintain normal cardiac output, and this normally presents as arrhythmia. An arrhythmia is an abnormal heartbeat. It can show with valve disorders, different cardiomyopathies, which are basically heart diseases, cardiac failure. And again, if the heart can't effectively pump, that can lead to circulatory shock where the circulation is not providing enough perfusion to body organs and tissues. Vascular or distributive shock means that the arterioles have lost their normal autonomic muscular tone or dilate dramatically, and this can happen when there is septicemia, which is infection that's throughout the blood. It can also be due to neurogenic shock or anaphylaxis, and so if there's a problem with the nervous system, which would lead to neurogenic shock, that can affect the distribution of blood. Anaphylaxis is a condition where the body is responding abnormally and extremely to an allergic, it's an allergic response, abnormal. Okay, that was a blooper. I'm not going to cut it. Last, we have an obstructive shock, which is blockage of blood due to something like a pulmonary embolism, a tumor, or cardiac tamponade, which is an accumulation of fluid around the heart. So if usually in the between the visceral and parietal pericardia, if there's too much fluid accumulating, that actually obstructs the heart and keeps it from beating normally, so that can cause obstructive shock. If blood pressure is falling rapidly, that is a relatively late sign of hypovolemia and the patient is in trouble. That's something important for you to know. I'll say it again. If blood pressure is falling rapidly, that is a relatively late sign of hypovolemia and the patient is in trouble. So make sure you know that. So we're going to take a look at the development of blood and fetal circulation. And these circulatory elements actually start to form in the embryo usually about within the first few weeks, maybe 17, 18 days of life. And that's when blood vessels are going to begin to form, and the precursor cells for blood vessels are called hemangioblasts. And hemangioblasts will in turn differentiate into what we call angioblasts. Angio means vessel, so these angioblasts are going to give rise to blood vessels and to pluripotent stem cells. And those pluripotent stem cells are going to further differentiate into the formed elements of blood, which are red blood cells, white blood cells, and platelets. So together, those cells are going to form masses called blood islands that are kind of scattered throughout the embryonic disc. Hopefully you were taught about the embryonic disc in AMP1. There are 3 layers: an endoderm, an ectoderm, and a mesoderm. Actually, the mesoderm is the middle layer, and all 3 layers contribute to epithelial tissue. So as those blood islands are scattered throughout the embryonic disc, the endothelial lining is going to start to form as those cells undergo mitosis, and mesenchymal cells are going to start to form the smooth muscle and connective tissue layers around the vessels. And while those are developing, that's when those pluripotent stem cells start to form blood cells. So there are also other tubes that are developing on the blood islands, and they will eventually connect with one another. They call them vascular tubes. And so basically these tubes are forming, and there's one central vessel that's being created, and new vessels are forming from existing ones, and they all start to join together. Angiogenesis is a term that means the creation of new blood vessels from existing ones. And the process of angiogenesis actually continues throughout our life. If a person has cancer, those cancer cells tend to send out angiogenetic factors so that blood vessels go to the tumor to feed it. I always think of the Little Shop of Horrors with that plant from outer space that wanted blood, and so he's like, feed me. And anyway, angiogenesis provides blood flow to cancerous tumors. If people put on weight, then they have to have more blood vessels going to more of the body mass, so that also causes angiogenesis to occur as people put on weight. So in terms of whether a vessel will turn into an artery or vein is dependent on signaling factors, growth factors that are going to determine what proteins are made by those cells and how big everything will develop. So as an embryo grows inside that uterus, remember that it's developing in a fluid environment. It's going to be surrounded by amniotic fluid. So we're going to take a look next at that circulation that occurs. We can actually see it in this video. We can see it, I should say, on this slide. You can see the umbilical cord from mom is forming what's known as the umbilical vein. And so that's going to go through it's actually going to go through the tissue of the liver on the posterior aspect of the liver to join into the inferior vena cava in an opening known as the ductus venosus. And I'm going to move this over to the next slide so we can take another look at that. Here we have a picture of fetal circulation, which is really simple and clear. And so what I want you to pay attention to is the left side of the picture, where we can see the placenta, which is attached to the inner wall of the uterus. So fresh oxygenated blood from mom is coming through the umbilical vein to the baby's heart. That's why it's the umbilical vein. It's going to the baby's heart. And in order for the umbilical vein to get fresh oxygenated blood in that direction, we're going to notice that there is a special area that is where we have an opening for that vein to enter the inferior vena cava for blood to go to the right atrium. And so that umbilical vein is actually part of the posterior wall of the liver, and the opening that's there is called the ductus venosus. So we've got fresh oxygenated blood from mom going through the ductus venosa right at the posterior aspect of the liver. It's part of the liver tissue, and it's going to empty into the inferior vena cava and go to the right atrium. Now, we have blood returning to the right atrium from the superior and inferior vena cava as well as through the coronary sinus, and that blood, a lot of it can go from the right atrium into the left atrium because there's a hole in the interatrial septum, and that hole is what we call the foramen valley. And so some of the blood in the right atrium is going to go right into the left atrium, where it will go into the left ventricle and then through the aorta, so we have oxygenated blood going to the baby. Some of the blood in the right atrium is still going to go into the right ventricle, where it's going to go into the pulmonary trunk, and you'll remember there's that special bypass from the pulmonary trunk into the arch of the aorta called the ductus arteriosus. And so again, that's another way to bypass the lungs. Now, the lungs are not bypassed entirely. There's still blood flow going there because the lungs are going to need some fresh oxygenated blood for their development, and they're going to need to bring blood back so that the deoxygenated blood used up by lung tissue can come back to the heart and get recirculated. And you'll notice that as blood comes out through the arch of the aorta and then through the thoracic and abdominal aorta, and then splits into common iliac arteries. From the common iliac arteries, we have special umbilical arteries which are going to go back to the placenta. Okay, so the umbilical arteries are going to take blood back to the placenta, but we do have blood flow throughout the body of the fetus. Now, once the child is born, the ductus venosus will close off, becoming the ligamentum venosus. The foramen ovale will close off, becoming the fossa ovalis, and then the ductus arteriosus will close off, becoming the ligamentum arteriosum, which is what you saw in lab when you did the heart module. So in the end, which this is the last slide for this part 3 of 4, it's really important to make sure you eat and maintain a healthy diet. Stay away from processed foods as much as possible. Make sure you're watching sugar and salt intake. Some salt is important, especially iodized salt, because the thyroid gland needs that to produce T3 and T4. It's important to control weight, to get regular aerobic exercise. It's at minimum 30-minute walks daily. If anybody is smoking or even vaping, the chemicals in the vaping fluid are just really carcinogenic, so that leads to a whole host of other problems and can damage the heart as well. So adopting healthier habits, reducing stress will help lower blood pressure, slow down the formation of plaques, and it's really the best way people can keep themselves healthy. So have a healthy heart, and this ends this video.